accreta, cesarean hysterectomies, and hemorrhage. VBAC is successful about 75% of the time. Most women are candidates, and about half of women are interested in the option. And VBAC results in lower maternal morbidity and mortality rates in the current delivery as well as in future deliveries. Yet VBAC is simply not occurring in many communities throughout the state of California, resulting in a 9% VBAC rate statewide. According to Barger 2013, a study looking at the prevalence of VBAC bans in California, quote, among the 56% of hospitals that offer a trial of labor after cesarean or TOLAC, the median VBAC rate was 10.8% with a range of 0 to 37.3%. According to the nurses surveyed, we found that about half of hospitals with continuous anesthesia coverage did not offer TOLAC, not because of an explicit hospital policy against it, but because physicians are unwilling to stay in the hospital with a woman attempting TOLAC, end quote. So even in facilities that offer VBAC, attaining one and avoiding surgery can be elusive. In fact, rates of VBAC among moms without a prior vaginal birth in the hospital is 63% and 86% at home. It is within this climate that women choose out-of-hospital VBAC. For many women in the state, VBAC is simply not a viable option at their local facility. Barger found that, quote, the mean distance from a non-TOLAC to a TOLAC hospital was 37 miles as the crow flies, with 25% of non-TOLAC hospitals more than 51 miles from the closest TOLAC hospital. In 2012, 139 hospitals offered TOLAC, which was 16.6% fewer than in 2007, end quote. So the trend is moving towards fewer hospitals offering VBAC. For some women traveling to a hospital that offers VBAC and accepts their insurance, that's the overlap we're looking for, right? There's a huge burden consisting of coordinating work and school schedules, vacation and sick time, and the cost of travel and childcare. We do not want to be in a position where state troopers are attending births on the side of the road as women drive long distances during labor to birth in a facility, in a hospital. As Dr. Elliot Main, the medical director of the California Maternal Quality Care Collaborative, has stressed, quote, in California, we are seeing a lot of hysterectomies, accretas, and significant blood loss due to multiple prior cesareans. Probably the biggest risk of the first cesarean is the repeat cesarean, end quote. Women should not feel like home VBAC is their only option, but for too many women, their choice is limited to home VBAC or repeat cesarean. If a hospital VBAC is not a possibility and the choice of out-of-hospital birth is removed, that essentially forces women into either unwanted and unneeded repeat cesarean surgery and the increasing risks that come with multiple prior cesareans, or into unassisted home births where they deliver without a midwife or doctor. In light of the recommendations made by ACOG and the NIH and the realities of increasing maternal morbidity rates in the state of California due to multiple repeat cesarean sections, the objective should be making VBAC more accessible, not less. Thank you.
Perhaps the folks who were involved with the legislation could offer some insight into the discussions, because there is a difference in the language between little I and little double I, that any pre-existing maternal disease or condition likely to affect the pregnancy, and then in the double I, significant disease arising from the pregnancy. So there appeared to be an intention that the impact was going to be reviewed differently from the first one versus the second one.
Actually, I can speak, Shannon Smith-Crowley, OB/GYN lobbyist. In that discussion, really what we did with VBAC was there were specific things that were excluded, such as multiples and other than vertex and then the dates. We left VBAC for the pre-existing maternal disease or condition to be evaluated with a physician consultation, so that there was a vast difference in the reason for the C-section, in the type of C-section, in the length of time since the last C-section. All of there's a lot of variables, so that was something that theoretically, I do know of VBACs that have been signed off by this year in terms of being able to find physicians who are willing to assess that it won't affect the, likely not to affect the current pregnancy. So that's why we separated that out rather than doing, actually ACOG would have preferred to do a blanket prohibition. But this was our compromise.
True, and Susan Bonilla, the author of the bill, was very clear every time it was discussed and in very public occasions that we would continue to be able to do VBACs. Very clear.
That's why we have it the way that we do, instead of the exclusion that was our preference. So we compromised.
Right.
What about the word of the use likely? Are there specific discussions that occurred around that use versus other possible terms?
Yeah. Specific to VBAC or in general?
In general.
In general, the likely was, like Shannon mentioned, it's more specific than may. It was intended to be like a high burden of likelihood.
A higher burden than may. May, just about anything in the kitchen sink could fall into that one. And that's in your standard of care, is may affect the pregnancy, I believe. But we specifically made it less broad. We did not attach any type of numerical value to it because it is, as Dr. Trong was saying, much more complex than just a straight legal number.
We have never agreed on whether VBAC should fall into big A, little I. As far as VBAC as a broad category, Cam has never agreed with ACOG on this up to this point. Maybe we'll get there. But we do agree that there are a variety of risk factors associated with VBAC, a variety of types of prior surgery and a variety of situations. So we can definitely break out VBAC into, say, a woman who has had a prior high vertical incision versus low transverse. You're going to be talking about very different numbers. On one of those, you're going to be, getting into the risk nearing, 10%, which we all agree for pretty much everything here. For a very seriously bad outcome, 10% is clearly not acceptable, versus an under 1% for a history of 1 or 2 prior low transverse incisions. So we are in favor of breaking up the history of cesarean section into different categories based on how different the outcomes can be with the subsequent pregnancies. So ACOG's own practice bulletin on on VBAC has recommendations based on different levels of evidence, and ACOG does recommend that VBAC or trial of labor after cesarean is the best option to, should definitely be offered to women who have had 1 or 2 prior low transverse incisions. So the 1 prior incision, the 1 prior cesarean, is at their highest level of evidence for reviewing everything in the literature. The 2 prior is the next level of evidence. There is less research available overall on that. And so when we're looking at likelihood, we're looking at a less than 1% chance for something to happen based on ACOG's own understanding of the research and the quality of the research. At the same time, ACOG's practice bulletin talks about the location of the birth, and they talk about, in their practice bulletin from 2010, recommending that a trial of labor happen in a facility with 24-hour anesthesia and obstetric care. immediately available, which, and we know what they mean by that. That is what they mean, but they don't say it. It's true. And that contributes to the VBAC ban that you were talking about.
And also, there's a lot of facilities who don't have 24/7 anesthesia and OB who do offer VBAC.
Mhm.
So I just want to be clear that it's not only facilities who are following that, and as I talked about, 50% of facilities that
Can
have
you use the
24/7
mic, please?
I'm sorry. I just noticed it. Just saying that immediately available is not defined by ACOG, so 24/7 anesthesia or obstetric coverage is the most conservative definition. However, that is not the definition that is employed nationwide or even throughout the state of California. And as I cited, half of the hospitals in the state of California that have continuous anesthesia coverage do not offer VBAC. So this is not so much as falling within ACOG's guidelines or risk-benefit analysis. There are other factors that prohibit access to VBAC at a hospital. And so, immediately available is a little squirrely thing. And in fact, 1/3 of when we look at the hospitals that ban VBAC in the state of California, 1/3 of those do have 24/7 anesthesia coverage. So if that was the sticking point, then why are all of these hospitals that have 24/7 anesthesia banning VBAC?
So yeah, absolutely, and that's definitely contributes to the access issue. So ACOG does make this recommendation, but they make it with C-level evidence, so which is basically clinical recommendations and clinic expert opinion. So the lowest level of quality of evidence informs the recommendation to have the emergency obstetric care available. So that's not to say that we don't want a woman having a trial of labor to have good access to the hospital. And so a midwife and a client between themselves in their disclosure, in their informed consent, are going to talk about things like how far do you live from the hospital? How quickly can we get there? Those discussions are going to take place. And it is possible in some cases that a woman is going to get her cesarean, if needed, as quickly in a transfer from home to hospital as she would in the transfer from a labor room to an operating room inside the hospital. That's not always going to be the case, but there are cases where that's also possible. So if we're looking at evidence-based care, it may not be in our best interest to expect us to determine the best place for a trial of labor after cesarean based on, anecdote, which is, basically what we're and routine and habit.
If I might, in 2005, when we adopted the standard of care, part of that was, and I'm looking at Regulation 1379.19, Part B, with respect to the care of a client who has previously had a cesarean section, but who meets the criteria set forth in the standard of care, the licensed midwife shall provide the client with written informed consent and document that written consent in the client's midwifery record that includes but is not limited to all of the following. Now, this was agreed to by ACOG at the time, and I don't see that anything significantly changed. There's not a preponderance of new evidence that would negate any of this. So the woman was to be provided with the current statement by ACOG regarding its recommendations for VBAC, a description of a licensed midwife's level of clinical experience and history with VBACs, and any advanced training or education in the clinical management of VBACs, a list of educational materials provided to the client's agreement to provide a copy of the dictated operative report regarding the prior C-section, permit increased monitoring, and upon request of the midwife, transfer to a hospital at any time or if labor does not unfold in a normal manner. And 5, a detailed description of the material risks and benefits of VBAC and elective repeat cesarean section. And as we have heard, and I can also personally attest to, often in clinical practice, a woman is scared out of the trial of labor by being told her uterus might split apart, but she's never offered the information of what that next C-section might do to her. And in the last 15 years, I've worked in 4 or 5 different medical practices where that's the case. There's a preponderance by the medical community to enlighten the woman as to what might happen if she has a trial of labor, and there's no or very little information given to the woman on what the possible consequences are to her down the road or at the time of a repeat cesarean section. So I think that if we're going to go down the road of requiring a referral for any woman who has had a prior cesarean section, we need to question what's new. Why are we now saying that she needs a referral when we didn't say it 9 years ago, and nothing in the intervening 9 years has pointed us in the direction that what we adopted in 2005 was not comprehensive enough to protect women?
Actually, if I can correct a mischaracterization of ACOG at the time, we never wanted home VBAC. We saw that it was going to happen, and so we agreed to the terms. And in fact, before the prior executive director of the medical board retired, she admitted to me that the medical board let some regulations that, Carrie, I don't think should go through, if they ever went through now, I think we would stop them, that allowed the written informed refusal. Nobody else gets to waive the scope of practice by saying, it's okay that my physician's assistant do the appendectomy. And the reason that she let that go through at the time was to bring ACOG to the table and do what we did last year. And you have well, maybe you do have an idea, how much it took for us to sponsor that legislation. And she knew that doing that, putting that provision into the standard of care and the regulations was going to be problematic for us, and that we would want to change it. So that's we never agreed to, we never wanted that. We were very clear about that. So I just want to make sure that the record is straight.
Okay, and I want to pose a question for people to think about. Is there any state where licensed midwives are permitted to do VBACs without a prior physician consult?
Yes.
Yes.
Allison Osborne again. I just wanted to say there are not obstetricians hiding under any rock in my neck of the woods who are going to see a lady and then grant some kind of okay for her to have a home birth. I have worked with obstetricians like in Humboldt County 30 to 40 years ago who did give okays. But it is not something that is possible in my area. They prefer to maintain a separateness, and then if they need to accept a transfer, they're very gracious, and it's fine. But it does not exist in my area to have anybody go into a doc and have them give some sort of benighting of whatever it is. So it's transfer or do it. And it's something I've been doing for 35 years. I've been doing VBACs. I was at one of the first VBACs at out of hospital in California. And women are going to continue doing it, and we are going to develop another set of doulas or non-licensed midwives who are willing to attend unusual circumstance births if we forbid midwives. My informed consent is not like, oh, it's rosy. It's very comprehensive. And I'm sorry, this is something that's going to continue to happen in California. You're probably glad. And I hope that we can have good